So good afternoon, everyone, and welcome. Thank you for joining us today. Today, our webinar is called The Power of Starting HPV Vaccination at Age 9. My name is Shantae Davis Patterson, and I am the Program Director of California's Comprehensive Cancer Control Program, which administers the State Cancer Coalition, the California Dialogue on Cancer, or CDOC, which is one of the co-founders of the California HPV Vaccination Roundtable in collaboration with the American Cancer Society. So today we have invited three amazing presenters representing three types of health delivery systems to showcase successfully adopting the shift to starting the HPV vaccination at age 9. So here's some housekeeping notes here. Please keep yourself on mute. You can ask questions in the chat box. We are going to let all of the presenters present, and then we will go and open a Q&A at the end of all of the presentations. So just note down all of your questions that you might have, or drop them in the chat. We are recording this webinar, so it will be available afterwards, posted on the Roundtable's website. And then we also have an evaluation that we'd like you to complete to help us improve future sessions. So this special webinar is being brought to you by the Engaging Health Systems and Providers Work Group of the California HPV Vaccination Roundtable. And happy HPV Vaccine Week. I should have started with that. It is HPV Vaccine Week. So just for those of you who are not familiar with the California HPV Vaccination Roundtable, we are a coalition of diverse stakeholders with a mission to work together to prevent HPV-associated cancers and precancers by increasing the California HPV vaccination rate to 80% by 2026. And there's our website at the bottom, cahpvroundtable.org. So today, our agenda, we will be going over California HPV Vaccine Week. This is something that has been piloted and created by the California HPV Vaccination Roundtable. So we're really lucky to have our parent work group present on HPV Vaccine Week. And then we'll go through our case presentations, hearing from Vista Community Clinic, Kaiser Permanente, and Rady Children's Hospital. And then after all of the presentations, we'll have a Q&A. So I'm going to start off and we're going to open it with our first presenter. So Dr. Sawyer, oh, and I want to note that all the bios are being dropped in the chat if Joyce hasn't dropped them already, just so we can forego lengthy introductions. So please do take time to read about our presenters in the bio document that's dropped in the chat. So we are going to start off today with Dr. Mark Sawyer. He is a professor emeritus of clinical pediatrics and pediatric infectious disease specialist at the UCSD School of Medicine and Rady Children's Hospital in San Diego. He is a part of the leadership team of the California HPV Vaccination Roundtable and a very valuable member of our health systems and provider work group. So let me turn it over to Mark.
Thanks very much, Shantae. Good afternoon to everybody. As Shantae mentioned, I'm a pediatric infectious disease physician at UC San Diego, and I have had a long-standing interest in vaccines. And I'm going to give a little background to get us started for what I hope is a robust discussion about this idea of moving HPV vaccine initiation down to 9 years of age. I've been most frustrated by HPV vaccination rates during my entire career. There's been no other vaccine that has been so slow in uptake. And this figure, which many of you have seen many times, illustrates it. It shows coverage rates that by 13 years of age for 3 vaccines, the meningococcal vaccine, Tdap vaccine, and then in the red box are different versions of HPV vaccine. And I'm not going to belabor the details, but we clearly have a problem. The HPV vaccine is lagging way behind the others. It's been lagging for a long time, almost 20 years since
Someone's
this
at the
vaccine
front doorbell.
became available. And we basically, I think we need to open our minds and think about new approaches to this problem, because HPV causes more deaths in California and the United States than measles and chickenpox and pertussis and diphtheria and tetanus combined by a long shot. So we need to really keep working on this. Next slide, please. So just like when any lofty goal remains out of reach, I think you need to retool. It definitely requires persistence, and we've been working at this a long time. We learn from our setbacks, but I think most importantly, we need to reassess our strategies and resources regularly. Oops, sorry, my phone's going off. I have to make it stop somehow. There we go. And although we have made some progress, and we should celebrate those milestones, I think we need to continue to seek support and collaboration and broaden our effort. And that's what today's presentations are about. Next slide. So we're trying lots of things. It's not like we haven't been engaged in this for some time. Presumptive communication approach has shown to be very effective. We're educating the community about the link between HPV and cancers. We're introducing reminder recall systems in doctor offices. School-based immunization has been tried and has been very successful in some places. Quality improvement projects with provider-specific data. And what we may see in the very near future is the possibility of a single dose of HPV vaccine being adequate for at least low-risk people. But I still think we need to keep thinking and develop additional strategies. Next slide, which takes us, of course, to we need a new strategy next. How about HPV vaccine at age 9? Next slide. So this is obviously the immunization schedule. And not sure if you've ever stopped to think why there's a big line of yellow boxes at 2 months, 4 months, and 6 months, at 12 months, and at 4 or 5 years of age, as well as 10 and 11. And the reason for that is this first bullet under the general approach to deciding when to give a vaccine. We want to give a vaccine as early in life as is justified by the rate of disease and as early as they will work. So we can give hepatitis B and vaccine and RSV prevention at birth because it works, but we cannot give DAP or Hib or others until 2 months of age. And that's why they all stack up at 2 months of age. We do cluster vaccines in similar ages to facilitate delivery. And that's why the HPV vaccine is currently at age 11, even though it is approved by the FDA to start at age 9. But the whole purpose of the schedule is to provide flexibility. And we now have that dotted, you probably can't see it, but there's a dotted yellow box that allows for HPV vaccine to be started at age 9. Next slide. I'm not going to belabor the effectiveness of vaccine. We've known for many years, this is a 5-year-old study that shows how effective HPV vaccine is at preventing cancer, with unvaccinated people shown in the orange bar and the rate at which they develop cancer and precancerous lesions, and the fully immunized people in the green bar way at the bottom. And there have been many studies since then which have reiterated this effectiveness of the vaccine. So we have a vaccine that works perfectly well. It's very safe, despite what you may read on the internet about concerns about HPV vaccine safety. I would argue it is one of the safest vaccines we have. There are no common serious side effects. Next slide. And we know that you've got to get it done in time before people are exposed to HPV. So this shows the effectiveness of vaccine at 12 to 13 years of age, 14 to 16, and 16 to 18. And it goes down very rapidly in terms of effectiveness. So we have to get people immunized before they're 12 or 13 years of age. Next slide. And we know that starting HPV vaccine at age 9 increases the chances of completion of the series by 12 or 13 years of age. This is a study from a couple of years ago in England that looked at proactive initiators. Those are people who started at age 9 versus routine initiators that started at age 11. And you can clearly see the increased percent that finishes the series, gets completely vaccinated by the time they're 12 or 13. Next slide. So are there any downsides? Why haven't we already done this? Well, we have the CDC recommendations, which have still to suggest giving it at age 11 as the routine. Some physicians are worried about waning immunity. If we give it too soon, is it going to wear out? And then this idea of clustering vaccines at similar ages to facilitate delivery. But I would argue that 20 years has shown us that clustering or no clustering, we're not doing a good job of delivering HPV vaccine. And I cannot think of any other downsides to starting at age 9, but we can bring that up in the discussion. Next slide. This is data on the durability of vaccine. I'm not sure why that black bar is on my slides, but hopefully you can see the graphs, which are titers over 10 years. And that's as long as we have long-term data. So I cannot absolutely prove that HPV vaccine will be effective for 20 or 30 or 40 years, but every indication so far is that this vaccine immunity is durable. So we don't really have to worry about waning immunity, which leaves us with nothing really to worry about starting at age 9. Next slide. So the American Academy of Pediatrics recommends starting at age 9. The American Cancer Society does as well. CDC ACIP now certainly allows for age 9 immunization, and the ACIP is currently discussing changing their language even further towards the AAP and ACS language, which is to start at age 9. The advantages we've already touched on. It minimizes discussion about sexual transmission in addition to the other things we've talked about. You're more likely to complete the series. It reduces the number of injections at the 11 to 12-year-old visit. And I think one of the reasons we are lagging in HPV coverage is some adolescents don't want to get all 3 shots at one visit. So they'd be happy to get it spread out a little bit more. So it makes you more likely to complete the series before people become sexually active, and therefore we can prevent cancer. Next slide. So that's my overview. Happy to take questions when we get to the Q&A, and I'll turn it back over to Shante.
Excellent. Thank you so much, Mark. All right, so next we have Bridget Freely from the American Cancer Society. Bridget is also one of the leads for our for the parent work group for the HPV vaccination roundtable, and helps to lead the whole California HPV Vaccine Week effort. So I'm pleased to turn it over to Bridget Freely.
Hi, everyone. Thank you so much, Shante. And I do want to reiterate, this is a work of many people. So I'm honored to be able to present it today, but it is definitely a whole work group effort. But we can go to the next slide. So one of our biggest efforts as the parent work group is our signature annual public awareness campaign that's led by the Roundtable. It's called California HPV Vaccine Week. I know Shante mentioned that before. It takes place the first full week of August each year. And the goal is really to raise awareness of the HPV vaccine as cancer prevention, really focusing on the promotion of the HPV vaccine for kids between the ages of 9 and 12 throughout the state. This year is actually running on August 3rd through 9th, so we are well underway, and you may have already seen some communications about it from some of our email blasts or other meetings, but I just want to share a little bit more about what we have available. We can go to the next slide. So as part of this campaign, our parent work group has created a lot of materials with the goal of really helping our partners, such as coalitions, health systems, health plans, primary care providers, really anyone doing HPV vaccination work, to help promote the importance of HPV vaccination in their communities during HPV Vaccine Week, but also beyond that as well. Some of our offerings, I'll run through this quickly and then I'll show you some screenshots in just a moment, but We do have a dedicated website for our California HPV Vaccine Week campaign on our Roundtables website. This includes, we have social media resources with HPV-related cancer survivor stories and social media graphics. Our Roundtable has dedicated Facebook and Instagram accounts. The handle is at CAHPV Roundtable, so please give us a follow and engage with our content. I know we're particularly active this week. We also have a dedicated campaign guide that lives on this website. This is a very easy to use PDF document we created, and it just provides general information about California HPV Vaccine Week. Also, key messaging examples such as newsletter and email blast templates about the importance of the HPV vaccine that we hope systems can just easily put into their existing communications. And we also have some resources to external links and learning opportunities as well. I do want to note too, our campaign guide hosts all of our social media assets with suggested captions for various social media platforms as well. And we also, every year, we work with key partners throughout our state to host dedicated webinars, just like today, really just to share the importance and all the great work that's going on throughout the state for HPV vaccination. So we can go to the next slide. Just some screenshots. As I mentioned, we have a dedicated website for Vaccine Week, and this is just a picture of kind of our homepage. I did link this here in the slide. I'm happy to pop it in the chat as well. And please feel free to go in, take a look, and share with anyone that might be interested in using these resources. We can go to the next slide. I wanted to also take a moment to share some screenshots of our social media assets. These are our testimonials from HPV cancer survivors that our work group identified. We have both videos of their stories as well as still images with quotes as well. And I will say storytelling is just one of our most powerful assets that we have available. And we can go to the next slide. These are just some snippets of our fact-based posts that we have on social media. This isn't everything. We actually have quite an extensive offering of social media assets, but I just wanted to give you a sense of some of the materials we have available. We also do have assets in Vietnamese as well as Spanish. And we can go to the next slide. So the last couple of years, we've had some funding to do this work, to do paid ads on both Instagram and Facebook. We actually took some of the content that you just saw over the past couple of years to create paid ads. And through that, we reached about 1.7 million people throughout the state of California. And through webinars like this, we've been able to reach hundreds of health providers, health professionals, others passionate about HPV vaccination throughout the state. We can go to the next slide. But one thing I want to note, I know funding for these efforts, especially as you're thinking of your efforts in your own organizations, I know funding isn't always possible, and we actually ran into that a little bit this year. So I also just wanted to share some ways that we are building on our efforts and accomplishing our goals without kind of those extensive dollars that we had in previous years. So this year, we're actually taking some of the talking points that we used for our previous testimonials and doing a really broad call to action for stories in the community from HPV-related cancer survivors, parents, young people, providers, really anyone who's passionate about HPV vaccination. And we're asking them to record a 30 to 60-second video of their story, share on social media throughout Vaccine Week, and tag our Roundtable social media accounts and use some hashtags. You can actually find, this is a snippet of what's in our campaign guide, but you can find these instructions in our campaign guide. And I will just say we've received some amazing testimonials so far, and there is still time to record. So please feel free to record a video on Instagram and Facebook, tag our page at CAHPV Roundtable on Instagram or Facebook, and please feel free again to just engage with our content throughout the week. I do also want to note, this is kind of hot off the press information. We have identified some media spokespeople, physicians, survivor speakers that were willing to speak to the media. And as of this morning, we've had 2 local media interviews with local news stations in Sacramento with a couple of our physician spokespeople, Dr. Alex McDonald and Dr. Eric Ball. So we're really, really excited for that. We actually have a 3rd opportunity in the works, but it's still pending. So I won't share too much about that yet. But I just want to say thank you so much to everyone. And I do want to just make a note that I know Vaccine Week ends on the 9th, but I do want to note that our resources and messaging, a lot of it is not dated, so it can be used at any point throughout the year when you're working on HPV vaccination and need some additional resources. And just a huge thank you to the team that made this happen. Kim Woodster-Chill, she's our social media lead, so pretty much all the assets you just saw and work on social media, that is Kim leading that charge. Margot Stack-Babich, who's our parent work group lead with UCSD Morris Cancer Center, has been doing a lot of the media outreach and coordinating all those great opportunities. employees, Jane Gray, Raquel Arias, and also Shantae, Joyce, and Sheila, and the entire health systems work group. So just thank you, everyone. And we'll be sending out a summary of all our great accomplishments throughout this week. So keep an eye out for that. And with that, I will pass it back to Shantae.
Awesome. Thank you so much, Bridget. Yeah, please take a look on the HPV Vaccination Roundtable website. And Joyce, if you can drop that in the chat, if you haven't already, that would be awesome. All right, so now we're going to move on to our first case presentation. And we're going to hear from Vista Community Clinic. And we have Alyson Kaye. Alyson is the Assistant Director of Pediatrics and the Nurse Practitioner Float Supervisor for Vista Community Clinic. Alyson is a friend of the roundtable, as we have called on her expertise previously. So we're very happy to have her back sharing her work for this Start at 9 webinar. Alyson.
Hi, everyone. I'm very happy to be here. You can go to my next slide if you want. So I am going to be highlighting some best practices and some system changes that we have made over at Vista Community Clinic to improve our HPV vaccine rates. Next slide, please. So just a quick introduction. You're welcome to read my bio, but I'm Alyson, and I have been a pediatric nurse practitioner in primary care for about 15 years and have been working as an HPV vaccine champion for a long time, more than 7 years, I think, by my count. And for those that may not be familiar, Vista Community Clinic, we're an FQHC. We're actually based in Southern California, but we have locations that are spread across several counties: San Diego, Riverside, Orange, and Los Angeles counties. And fun fact, we were founded in 1972, and the first Vista Community Clinic was actually based in the basement of the Vista Animal Shelter, which I think is kind of a cool fact. Next slide, please. So where did we start? So prior to 2018, our HPV vaccine series completion rates were really abysmal. They were as low as 25% in some of our clinic sites. We were only offering the HPV vaccine at age 11. It was part of our routine immunizations, but we really didn't do any outreach or education beyond what is the normal scope of practice, like in the setting of primary care. Next slide, please. But we were very, very lucky that in 2016, we were approached by the American Cancer Society with a project that would be focused at improving our HPV vaccine completion rates. And that is really what kind of spearheaded this and started our drive to improve this. We assigned a clinician HPV champion, and that person's job was to reduce, barriers and improve clinic workflows. And that person was me, which is how I kind of ended up in this role. So we started basically from scratch a long time ago, I guess now. And the first thing we did was really start with comprehensive education. So we actually really started talking about the HPV vaccine at age 9 a very long time ago. It was always approved to be given at age 9. So we felt that if we at least started the discussion early, we might have better chances of getting that vaccine completed. We did, in fact, start bundling it with the Tdap vaccine at age 10. At the time, there was a recommendation due to a pertussis outbreak that you could give the Tdap vaccine at age 10. So we started saying to parents, well, let's do your Tdap and first HPV at age 10. And then when you come in for your age 11 visit, you can get your MCV and your second HPV dose. We also, several years ago, created a quality team, which is focused on improving pediatric immunization rates. So they don't just look at HPV. We actually look across the spectrum, from infant vaccines all the way up through our adolescents. But that team has been very hard at work over the last few years, looking at different ways to improve our immunization rates. Next slide, please. So what has worked? I would say some of the biggest things that have worked for us is changes to our immunization clinic workflows. So we started allowing and encouraging staff to offer the HPV vaccine to patients starting at age 9. Basically, as soon as they added that little box that Dr. Sawyer showed, where it was on the immunization schedule, we really pushed to have our staff start offering it. But I highlighted the next change because I think, as I've watched the data over the years, that this has been a huge help. Our EHR system actually now forecasts the HPV vaccine at age 9. You can see kind of there what it looks like. And you can see if you look down on the bottom, that's a patient who got their first dose, and now it will be forecasting that they need their second dose. So once that first dose is given, our EHR automatically forecasts the next dose when it's due. We've done a lot of patient outreach over the years. We've done text messages, postcards, social media campaigns. I'm still sort of surprised how successful the postcards were. Patients actually brought them into our immunization clinic and said, I got this in the mail. It said I was due for this. So I think sometimes we forget in this age of technology that sometimes simple things like postcards actually can make a difference. It also became apparent that we needed specific education around the HPV vaccine for patients. So we designed an HPV Mythbusters handout, which is looking specifically at those things you hear, that HPV causes infertility, that HPV vaccine isn't safe. And I'll show an example of it later, but we still use that in clinic to this day to try to address those very specific concerns. We also implemented a vaccine refusal form, and I'm sorry, my picture seems to have kind of overlaid that for some reason, but we have a vaccine refusal form that patients sign when they refuse any vaccine, not just the HPV vaccine. Next slide, please. So where are we now? So as of June, I'm very happy that our overall adolescent vaccine completion rate is at 65%. So those are patients who have had a medical visit with us in 2025 and have had kind of all 4 doses of the adolescent vaccines by their 13th birthday. And my own clinic site was actually as high as 69%. I've been tracking our 9 and 10-year-olds for a couple of years now. I have a quarterly report that sends me where we are. And as of July 1st, I was really pleased to see that 67.8% of our patients who are 9 to 10 have had at least 1 dose. And in fact, 34% had actually had both doses of the HPV vaccine. And that kind of looks back over the next year. It sends me a report every year. Next slide, please. So this is what our Mythbusters handout looks like. And you can see it kind of just addresses those very common ones you hear. It's not important. I'm not at risk. This was developed between myself and our pediatric director when it became clear that we were kind of hearing the same refusal reasons over and over again. And we still use this in clinic when, to target those specific families that have specific concerns. Next slide, please. So I think it wouldn't be fair if to pretend everything is always rosy and easy if I didn't also talk about the challenges we have had. I still would say the biggest one is this vaccine hesitancy and refusal. I think everyone on this call knows we're living in an age of misinformation. There's a lot of distrust in vaccines. I still hear fairly frequently that HPV is not a school-required vaccine, so they don't want to do it. And also it's less time sensitive, meaning that there's a big, broad range of ages where you can get it. And so parents, sometimes it's difficult to convince that giving it earlier is better. If you look to that picture to the right, that's actually a longtime patient of mine I happened to see in clinic last week. And as you can see, I have been unsuccessful in convincing this family that the HPV vaccine is safe and effective. And this is not kind of an anti-vax family. As you can see, they even do the flu vaccine. And yet, despite multiple conversations over many, many years, this parent still does not feel that the HPV vaccine is needed. And on the bottom is a picture of the AAP vaccine refusal form. That's the one we use when parents decline vaccines. Next slide, please. Other challenges we have had, we have added a lot of new pediatric clinic sites over the years. And with those new sites come new clinicians, new staff, and new patient populations. Sometimes it feels like we're starting over from scratch. We have to do a lot of outreach and education to retrain as to why we give it at age 9, why we feel it's important to give it at age 9. Sometimes it can be a little bit of a challenge to kind of get that entire site up to speed. Also, we struggle to get parents to come back before age 13, and we were finding that they don't often come in for those well-child visits at 12 or 13. So I would argue also that vaccinating at age 9, you have a lot more time to complete the vaccine series if the goal is to have it done by age 13. And that's all I have. I'll be happy to take any questions at the end. And thank you so much for having me today.
Excellent. Thank you so much, Alyson. That was awesome. All right, so now we're going to move on to a large health system, Kaiser, and we have Dr. Bronstein. Dr. Bronstein is a pediatric infectious disease specialist at Kaiser Permanente. He's a member of the Roundtable's Health Systems and Provider Work Group. And now he's going to bring his experience with Start at 9 at Kaiser. David.
Great. Thank you so much. Thanks for the introduction there. And thank you, Alyson, especially for your presentation. I was frantically jotting down notes for things that I want to apply in our system here. And I'm very jealous of your rates there. So we're going to have to talk a little bit afterwards here for sure. But I do want to talk about the experience that we've had with Kaiser Permanente, and specifically in Southern California. So if we can move to the next slide here, just to kind of give you an idea of scale, for Kaiser Permanente, we've got, 12.6 million members throughout the country. 4.9 million members are in Southern California. It's the largest of our areas there, with 16 hospitals, 202 medical offices, over 8,800 physicians, and over 90,000 employees. So very big scale, I would say. And so sometimes it takes us a little bit longer to make and spread interventions. And as you'll see, sometimes we do things quickly that we're just not necessarily as prepared for as we should be. If we go to the next slide here, our HPV interventions really started about 10 years ago. And we started as a little pilot in my own area, Antelope Valley. So a little bit north of Los Angeles there, not the biggest of medical centers at the time. Then we had, I don't know, probably a little over 100,000 members at that time, more than that, but not very big. And so we realized that, hey, we're flagging all these immunizations that need to be given, but have we really taught people how to talk about it, how to communicate around it? And so we really started this whole process, which was a PI, performance improvement CME project, as well as maintenance of certification for our pediatric department, where we would do just a whole lot of educational communication type training, not just what to say, but how to say it. We would track our progress over time, even created our own metrics at the time to kind of follow how each individual provider and physician was doing. And it seemed pretty effective. So we decided to go ahead and spread it region-wide. If we can move to the next slide there we go. And so you can see we spread it to each of our 13 medical centers, and each area kind of told us what they needed as a department. Some wanted to use care actors, for example. Others wanted FAQ sheets, and we kind of tailored it around each area in terms of the intervention that seemed to work best for them. So if we move to the next slide here, you can see most of this work was done pretty much throughout 2016. And we saw some pretty dramatic improvement. Now, whether we can attribute it to this or other things, it's hard to say. And that's kind of the theme here, is a lot of the interventions that we've been doing, it's hard to know exactly what's impacting the rate, just because there's a significant lag between when you make these changes and when people ultimately are counted at age 13. And this shows really that HEDIS measurement of completing the series, so 2 doses by age 13 on the graph here. If we move to the next slide, please. This is really where age 9 came into effect for us. And so back in around 2018 or so, we had some discussions, or actually we really didn't discuss it much. It really felt like overnight it just happened, where on our, what we call our proactive office encounter, it's basically the flag in the computer system, the sheet of paper that we get on our desk that says what people are due for, whether it's screening tests, preventive measurements. So for adults, for example, if someone needs a mammogram, if someone needs a colonoscopy, an A1C check, a second blood pressure measurement, whatever, it's going to flag on that sheet that they need it, whether they're there for a well visit, whether they're there for an acute visit. No matter what you come to us for, whatever kind of visit you have this proactive office encounter, and our staff knows, our physicians know, we all know that if you're due for it, we got to go ahead and order this for you. For kids, of course, what usually flags is someone's due for a vaccine, whether it's the flu shot, whatever. And so for HPV, back in 2018, really just with one click overnight, they changed this POE sheet so that it would flag at age 9. And so we were kind of caught off guard. We really didn't have a chance to do really any education around it, or to even warn people this was happening. And there was really some confusion, I would say, at least throughout our region there. But it happened, which was absolutely a step in the right direction, as I think we would all agree. If we move to the next slide here, again, you can see where that intervention occurred, and numbers did what numbers did. And again, hard to tell if there's any sort of causal relationship there. But what was really missing, other than the education piece, was if someone came in for a well visit and we use our checklist in our electronic medical record, the checklist that basically checks which vaccines they're there for. If someone comes for an 11-year-old visit, it would be defaulted to check that they need a Tdap, that they need the meningococcal vaccine, and previously it would be, of course, defaulted that they need the HPV vaccine. We hadn't had it changed so that for the younger ages, that was checked off. So if a kid came in for a 9-year-old physical, for example, it wasn't pre-checked that they needed the HPV vaccine, even though on that proactive office encounter sheet, it said they were due for it. It wasn't that simple step of really doing nothing and the vaccine would be ordered for you. You had to go an additional step and do that. So if you move to the next slide here, we started having conversations with the folks who have control over our electronic medical record and the IT folks who can actually go ahead and make those changes to get something checked as the default on those order sets. And so we got some agreement. I thought it would be a lot more complex where we would need to add some sort of new physical because we have a whole range of 6-year-old to 10-year-old physical all in one sheet. But they said, no, you don't need to add anything new. It's just if someone's 9, it will check it on that 6 to 10-year-old physical order set. And so that's really what they were able to promise us. And so we thought, okay, if we're going to have this change, now's our opportunity to do some more region-wide education around this. And then the pandemic hit. And so all of our ideas of let's get this rolled out, let's go ahead and teach people about this, the pandemic hit. And this went into effect regardless of that. If you move to the next slide here, you can see that really towards the beginning of the pandemic, before we had a chance to do the education that all of us really absolutely knew we had to do around starting at age 9, this pre-check of the order set just happened overnight again one day. And so again, once again, we were a little bit caught off guard, I'm embarrassed to say, but at least we were moving the right direction in terms of getting this start at age 9 to be the norm for people. If we move one more slide forward here, finally, really because of good fortune here, we were able to start working on the education piece, which we knew we had to do, but there was a little bit of course, a lag for a number of reasons. And so this basically just kind of fell into our lap where we were able to partner with the research team who decided to start a clinical trial that was funded by the National Cancer Institute, looking at comparing a local tailored approach to quality improvement versus a more prescriptive approach. And so as you can see here, we used all sorts of quality improvement best practices that were used in other medical centers throughout Southern California, lots of different evidence-based quality improvement activities. And we basically randomized 80 plus of our pediatric clinics throughout Southern California. They were randomized in 3 arms of the study. So one was just usual care. We just didn't do any of the training with them. And then we had a prescribed group where everyone got the same interventions. And then we had a tailored group where there would be that pre-meeting. You would meet with the folks and say, hey, what do you need? What are your concerns? You would do all sorts of interviews before and after, questionnaires and such, and really understand the needs of a specific clinic and then design something based on their specific needs. And so if you move one more slide forward here, you can see the education pieces, the quality improvement pieces, the collateral, all the other things that we could offer through the study based on either prescribed or tailored interventions here. And so many of these, and why we're including, this education as the age 9, so much of this had to do with age 9. So the pocket card, for example, talked about the discussion of doing, starting at age 9. The flyers that we had, we made sure that they had, that it mentioned starting at age 9 and that it had younger looking kids in there rather than the older ones who were in the previous things. our education piece, the part I'm the most passionate about, also had a big emphasis on age 9. And so we brought in a communication expert from Northern California to actually do a large communication training. And again, so much of that was age 9. And then I myself made some booster videos that we would use for the clinics that were participating in the study, especially for the staff to be able to watch like a 2-minute video every few weeks, just to kind of reinforce a lot of the talking points, a lot of the conversation pieces there. And again, so many of the other things that we had, whether it's flyers, access to the records, as well as if you move to the next slide here, just really good ways of keeping track over the study period. So each individual who is participating would know how they're doing. And so each line there, this is one of our small clinics here somewhere in Southern California, and each line is an individual provider who seeing their successful opportunities if someone got the vaccine within 30 days of that appointment. And then included in the metrics that they would then follow on a monthly basis, we also put in little tips and tricks, just kind of subliminally to reinforce a lot of the education that they had received, as well as down at the bottom some kudos and really highlighting some of the high performers and such. So and again, it's just one example of the communication we would get, the feedback we would get on how each of us are doing with our vaccination. And so one more slide forward here. So again, I'm happy. Again, we don't have the Vista numbers there. One day we really hope to, and we hope to hit, of course, the 80% that we're all shooting for. But I'm encouraged that at least now we are beyond our pre-pandemic numbers. Okay, obviously we had a dip for lots of reasons during the pandemic. Now we're not just back to where we started, but we're continuing to show improvement. And I think now that we've finally got the educational piece and all those other interventions around age 9 that are going, especially with the study, we'll start seeing the improvements because of that, hopefully over the next year or two. So anyway, also happy to answer questions at the end if you have any, but thank you so much.
Thank you so much, Dr. Bronstein. All right, so we're gonna move on. And also if I can have the speakers that are still on, if you see a question in the chat to address, if you can address it in the chat, that would be wonderful. We'll still have a little time for the Q&A at the end. But now I want to introduce our next speaker, Cassidy Boyd from Rady Children's Hospital. She is a public health leader at the Children's Hospital, where she manages a multidisciplinary team within the population health department. I'll turn it over to Cassidy now.
Hi, everybody. Thank you so much for having me. I really appreciate it. So today I really want to talk about how we use our quality metrics to improve our vaccine uptake rate for HPV. We're also Rady Children's Health. I'm still getting used to the name myself, but just wanted to share that with everybody as well. We're going through a merger right now with Children's Hospital Orange County. But next slide. So I know you guys can read my bio, so I won't, bore anyone with the details, but I've been with Rady Children's for about 10 years now. I've worked with the foundation initially doing a lot of science writing for donors, moved into our research department pre-pandemic and got quite an education during the pandemic, especially around vaccine trials and research. And then moved into our now population health department, where I manage a wonderful team where you'll be able to see a lot of the fruits of their labor. Next slide. So Rady Children's Health, I'll be speaking specifically about our San Diego campus now that we are covering both Orange County and San Diego. But we are one of the top 10 pediatric healthcare systems nationwide. We care for over 300,000 patients in our pediatric population. That's about 92% of the region's children. We also take in patients nationally and internationally. We are one of the largest children's hospitals in California and growing. We currently have a great deal of crazy construction on main campus. Our 7-story medical tower is under construction, so you guys might be seeing lots of cranes from the highway. And we are also so thrilled to be merging with Children's Hospital Orange County under the single parent entity of Rady Children's Health. Next slide. Okay, perfect. So we are an integrated health network, but what does that mean? So we have hospital specialty and 60 primary care offices with over 200 primary care pediatricians all across San Diego and Riverside counties. We take HMO, Medi-Cal managed care, PPO contracting, all of which look a little bit different when it comes to, vaccines and vaccine information. So we always try to create that consistency of information for our patient families. We first started managing risk back in 1993, and we have risk with Medicaid managed care plans and commercial private payers. We've been a hospital since 1996, and we have CPMG, which is our Children's Physician Medical Group, which oversees all of our primary care since 1999. So system-wide, over 300,000 unique Medi-Cal and commercial patients, but we do see a majority of Medi-Cal patients. And so with that, we really focus on a big data set called HEDIS, which I'll go into in a moment. Next slide. So measuring success, HEDIS, which some of you may already be familiar with, this is the Healthcare Effectiveness Data and Information Set. This is a widely used performance measurement tool developed by the National Committee for Quality Assurance, or NCQA. The Managed Care Accountability Sets, or MCAS, is a set of performance measures that the California Department of Healthcare Services, DHCS, selects for annual reporting by Medi-Cal managed care plans. Line Measure and Perform, AMP, provides similar kind of quality assurance, but for commercial health plans. All these sets, though, they really just work to offer standardized approaches for evaluation and comparing of healthcare organization performance. It helps to ensure consistency and reliability, and helps identify performance gaps for things such as vaccines and getting them done on time, which means starting early, starting at 9, and establishing realistic targets for improvement. Next slide. So the benchmarks themselves, NCQA HEDIS includes more than 90 different measures across 6 different areas of care, including effectiveness, access, patient experience, utilization, 19 of which are pediatric specific and fall within that age group that we're focusing on today. MCAS HEDIS, the group identified by NCQA metrics, those utilize 41 different metrics, 8 of which fall specifically into the children's health domain measures, including HPV vaccine. Some of these measures are inclusive of children and adults as well. We focus on 13 different measures that impact the pediatric population. Each of these come with industry benchmarks and incentives that providers can reach when they get to different ones of these, minimum performance level of the 50th percentile, 75th, 90th. Our goal is always, of course, everybody. The outcomes, of course, are proprietary of each PCP, just like I wouldn't talk on behalf of any of our other speakers earlier today. All I can do is kind of speak from the network perspective. So I want to dive a little bit further into IMA, which is the Immunizations for Adolescents metric, and how we use that and how we work early as possible, starting at 9, to try to get these done as soon as possible. So IMA, by the 13th birthday, all children who are eligible for this metric need to have 1 dose of their meningococcal, 1 Tdap, which is your tetanus, diphtheria, toxoids, and acellular pertussis, and 1, our favorite, HPV vaccine series completion. And also, happy HPV vaccine week. Next one. Okay, so within IMA, the metrics have specific benchmarks for each set of vaccines. So between the 9th and the 13th birthday, 2 or 3 doses are needed depending on, the age, immunocompromised, other kind of things, depending on what the pediatrician recommends. 176 days need to occur between the first and the second dose. And the minimum performance level that is set nationwide is about 36%. So it was so cool seeing our first speaker talk about her amazing rates of getting up to 60% or higher. That is wonderful. That is where we all want to be, and we can do that by starting as early as possible, by starting at 9 years old. Next slide. So how do we do it? So since 2021, we've had a team of patient care coordinators who have performed multimodal outreach to be able to close these care gaps. They work to schedule vaccine and well child appointments on behalf of parents. These are busy parents. They don't always have an opportunity to call, wait on hold with their office, things like that. So we take a proactive approach by reaching out to them. We also are looking for and kind of skimming the, immunization registries and other places to ensure that we have everyone's most up-to-date vaccine information. Tracking appointment completion is another big thing too, especially working in a Medi-Cal population. We want to make sure that those who have scheduled their appointments are able to make it to them. We know that things stand in the way, so social drivers of health is a big thing that we look at. We'll screen for things like food, housing, and transportation insecurity, because those are the things that could take away from going in and getting your child vaccinated for HPV. If somebody is identified as food insecure by our team, we have an in-house food navigator that can help them, identify and get food resources. Same with transportation. We utilize a lot of different systems, REDCap, EPIC, COSIVA for documentation and tracking health outcomes. And lastly, too, we do a lot of education on the PCP side. Of course, we know that all of our primary care offices and our providers are extremely expert in what they do, but we want to make their lives as easy as possible. So I have some screenshots in here of what the provider view looks like in EPIC. They can actually see when someone is coming due for an HPV vaccine and what the recommendation is, as well as getting some opportunities, what are called dot phrases, to be able to include information in like my chart, communications with families before they're due for it. So these screenshots are from a patient that's coming due that is not due yet for HPV. They're not yet 9 years old, to be able to start the conversation as early as possible, because parents are thinking about this as early as possible. Next slide. So some of our efforts from the last year, conducting telephone outreach really does make a difference. It sounds old school, but it does help. Screening members as well, we're able to get a lot of really good information as to what is standing in the way between families getting in to have their appointments completed, and being able to help identify that, address it, and also reschedule, helping people get back in. Okay, is it a transportation issue? All Medi-Cal plans are required to offer some semblance of transportation for medical appointments, helping them coordinate those things. We've done over 10,000 phone calls in a year, almost 6,000 MyChart messages, 6,000 records reconciled, and almost 2,000 appointments that might not have happened otherwise. With our completion rate, it's also an ongoing thing where we work with a closed loop method of being able to ensure that if somebody didn't get in, figuring out why, and then working with them to reschedule or find something that works. If they can't get into their PCP, where's their local Walgreens? Where's their local pharmacy? Can we help them get there to be able to have their HPV vaccine? Next slide. We also try to look through to see what's the most effective way to work with folks. Historically, it's always been, telephone outreach, but we really found that despite there being a higher percentage of people picking up the phone, those that are reading their MyChart messages are more likely to schedule an appointment and complete those appointments as well. Appointment completion was 21.8% higher for those who we communicated with over MyChart than telephone, which makes sense, right? You can kind of, under the table or whatever, hop on MyChart. It's a little bit harder over the phone. So we're looking at additional modalities as well, with text message and other ways to be able to get information out, to be able to start talking with families as early as possible, letting them know your child's due at 9, but even before 9, here are conversations that you're going to be having with your PCP to start to prime them for that. Next slide. We also looked at language as well. MyChart, the application, comes in multiple languages. We have a diverse team and an extensive translation department, and we wanted to check and confirm that communication over MyChart was still effective, even if in another language, a majority of which was Spanish for our particular population. And when comparing the impact of MyChart messaging between those who listed English as their preferred language versus another language, non-English families were 30% more likely to schedule an appointment than compared to those who were non-English speaking. So we really found that having someone being able to speak in their native language one-on-one, even if it was with a translator was able to help with MyChart, making sure that the language matched what they were used to and being able to see. So that way it was also culturally competent, making sure that the information being shared is focused on cancer prevention, and ensuring that age appropriate information is included to be able to have families feel more comfortable being able to say yes and moving forward with these vaccines. So next slide, I think that will be our last one. Yep. So again, for us, you know, when we're looking at quality measures, all of these things having to be completed by the age of 13, there's such a better outcome when starting at 9. We've definitely seen that, and we've seen it with communication, multimodal communication, phone, my chart, text message, getting out that kind of information as early as possible to families, long before they're due, long before 13, at 9, or even before, and also prompting the primary care offices to make sure that they're seeing that as well. Everyone from primary care, the PAR up front, the MA, the patient care coordinator are all working to try to get kids in starting at 9.
Thank you so much, Cassidy. That was a great overview of your efforts there. So we have 5 minutes left, and we want to try to squeeze in some questions in the Q&A. We're going to have Dr. Julie Dane come on. She's actually the co-lead for the Roundtables Health Systems and Providers Work Group. She's also a professor at for the Department of Public Health Sciences and Assistant Director for Community Outreach and Engagement at UC Davis. So Julie is here to help us moderate, and I'll turn it over to her.
Hi everyone. Amazing presentations. I think we got through most of the questions, but I do see 2 questions in the chat. So if the speakers can unmute themselves and turn themselves on camera, I'll start with the first one. So this one's a general question, and any of you are happy to answer that one. What kind of feedback have you all gotten from providers and clinic staff about the reduction in these types of concerns?
Sorry, this is Raquel. Just to add a little more context to that, I was asking about, you know, when we hear about start at 9, the benefits, it's like a reduction in concerns about sexual activity, also number of shots. Just wondering if that's been the experience of the providers and staff at your systems.
I've heard from a couple local providers who've tried this that before they started, some of their providers were concerned that it would be even more difficult to discuss at age 9 than 11. But in fact, the opposite was the experience. They did find that the connection between sexual activity and the vaccine was not so clear to parents. And as has been the focus for a while now, we're focusing on this is a cancer prevention vaccine, and you can get it at age 9, so why not?
I would echo that. I think I've had the exact opposite experience. I'm still in clinic 3 days a week seeing patients, and I find that when I presented at age 9, and I say let's prevent cancer, I just don't get a lot of pushback unless the parent has, vaccine hesitancy already. They just don't. And I think that's why when I look at our 9 and 10 data, it's been so amazingly successful. I think the hardest part we're finding now is we have to get them back into the clinic in their 13th year of life to count towards those HEDIS measures. And that's been one of the biggest challenges we've been working on this year.
Yeah, I would agree. The concern about, sexual activity really just doesn't come up much anymore. I think because we've gotten so good at talking about the cancer prevention, and even in places where the normal rational person should take a step back and think, wait, why would my kid get that kind of cancer? Most people don't make that connection, which is pretty interesting, to be honest with you. But I think the biggest benefit is not having to do so many vaccines at age 11, that it's so easy to say, well, let's give my kid a break and not do this one that they perceive as less important. So doing it as a vaccine by itself, or with the flu shot or the COVID shot or whatever else, but without the other 2 that normally would have gone with it, it's just so much easier to get people to agree to 1 shot versus the 3, at least in my experience.
I'll definitely echo the other speakers. When we're doing outreach, I hear from our team all the time that the conversations are much easier of parents of 9 and 10-year-olds than it is of 13-year-olds. The conversation more easily focuses on cancer prevention.
Okay, and you've answered both of the questions in the chat together.
I would also echo that the 9-year-old physical in primary care there's less to do than sometimes in the 12 or 13. There's less to talk about. There's less screenings in some sense. Unless they have chronic health issues, those visits, at least from my provider perspective, are slightly easier sometimes. So it gives more time to answer questions about vaccines instead of kind of trying to rush through the Tdap and here's this and here's that. I find that visit is a very vaccine friendly visit just because of the time and the less things that need to happen from an anticipatory guidance perspective sometimes.
And then from Raquel, any final words of recommendations?
Well, I would summarize it all by saying that this works. And if we can get more people to do it, they will benefit in terms of their HEDIS and other measures. And of course, the patients will benefit. So I hope we've encouraged some people to try this if they haven't already, and will help spread the word about their success.
And I would say one step at a time. I mean, I think we've been doing this since 2016. So, and this has been, there are some years where I would say it was very slow going. So one step at a time, you just have to, one meeting at a time, one this at a time, and eventually it does build up. And then just in the last 2 years, I can really see the improvement in our completion rates.
And for me, in retrospect, it is helpful to have the educational piece in place when you do make the change. So if you can at all get that coordinated rather than just, making it a checkbox that just shows up one day, people should know why it's there and how to talk about it. That would make life quite a bit easier.
Definitely how to talk about it, and talking about it in as many different ways as possible. Till you're blue in the face, till you think you're saying it too many times, say it 6 times more.
Awesome. Thank you so much for those final words. And also just for all of your presentations, all of the knowledge that you've shared for this webinar. Thank you all who have joined us. Please make sure that you complete our evaluation that Joyce has dropped in the chat. I know we're 1 minute over, but again, thank you all for joining. Please visit our website at cahpvroundtable.org and have a good rest of your day. Thank you.
Thanks, everyone.